All right, so I'm going to be talking to you about this project that we've been working on for the last 5 years at University of Washington. I'm really excited to speak to you on behalf of our department. This is co-sponsored by Academy of Emergency Ultrasound. It's been a joy for me, and thanks for letting me share it with you. We'll start here. You've got a patient, it's 4:30 in the morning, colicky pain, and you do an ultrasound. What do we see here? UVJ stone. And do you remember, like maybe when you're a medical student, or actually pretty much every new stone patient, having to be like, no, trust me, it's going to be fine. You go home, you're going to pass this. And they're like, what? You're not going to do anything? And I just remember thinking about that a lot when I was a medical student. And there's this gap where you reassure them. You're like, no. If this gets worse, then we'll do something. And they're like, worse? Like I had to come to the ER for this. And so this technology kind of fits in that gap. And so the second question that I would just say is, does your urologist want to be consulted for a 3 millimeter stone on a Friday night or even during business hours? And urologists are really frustrated because they're seeing these stones, we'll schedule them, and then the patient passes maybe even like a moment before. Thanks, Dr. Stern. I can speak up. So the patient passes their stone right before their urology appointment, and then the clinic slot is wasted. So we fit in the gap here. Using ultrasonic propulsion and a technology related to shockwave lithotripsy called burst wave lithotripsy. So these are the objectives of the talk, are to understand the role of ultrasonic propulsion in BWL. And then what I'd really like to do is, this is the first time sort of unveiling this to an audience of emergency medicine docs. I'd encourage you, as this technology continues to come out, to partner with urologists. We built a kidney stone pathway at the University of Washington to get follow-up for all kinds of conditions. And I don't imagine that any ER doc would be like treating without urology co-involvement, but this is a technology that lets us diagnose a stone and then apply a treatment to the stone at the UVJ in a pretty reasonable time frame of 10 or 15 minutes. And so it's something that I see us doing in the future, potentially. And then lastly, I just want to broadcast that stones are dynamic. And if you could walk away thinking kidney stones move, that's great. So I put the title of space in the talk, just trying to get some people in the room. Maybe one person might have come if they read the flyer and was like, what's going on with astronauts? But also because NASA was our sponsor. They've been a great collaborator. There's an increased risk of kidney stone formation among astronauts, and NASA has to mitigate this risk if they want to do extended space travel to Mars. They're not allowed to go until they can check the box and say, we've addressed kidney stones, we can keep them from forming, and if they do form, we can treat them. And so they've been a great partner for us. We partnered with them saying that the emergency department would be a space analog. So it's a lot cheaper to do a study in the emergency department than having to go to the space station, just in terms of rocket fuel units. So it's been really fun. The technology started with this kind of clunky machine on the left, and running MATLAB, and that's kind of an example of what it looked like. And then this is the Applied Physics Lab at the University of Washington. Has a commercial spin-off called Sonomotion, and we have an FDA IDE exemption. It's going through the process of FDA approval. So it's like coming to market, and I'm presenting preliminary data here that is unpublished but under review. And so just sort of broadcasting this as like, it's coming, not quite there, and certainly deserving of future study. There are two different technologies. This is our investigational technology. That's a phased array, standard phased array probe. And then there's this helical or circular probe that emits kind of like a cone that focuses and either pushes or dissolves. It's this high negative peak pressures, which are in megapascals, that impart the force into the stone. BWL, burst wave lithotripsy, I'll call it BWL from now on, is like shockwave lithotripsy. Imagine that it's giving the same force to the stone, but shockwave lithotripsy is like, you get, in the United States we do general anesthesia, it's painful. BWL imparts the same amount of energy, but it does it quickly, so it's a high frequency oscillation. And it sort of like resonates with the stone, think of like an opera singer in a wine glass, to then kind of implode the stone. Ultrasonic propulsion is more of like a flick, and it imparts, I'll show you, here's a video of ultrasonic propulsion under ureteroscopy. And then, whoops, let me try and give you, I gotta work out these transitions here. I think I have to click the image maybe. Here we go. Okay, so we're applying ultrasonic propulsion right there, and this clip is now looping. So this is a UVJ stone that is kind of like hung up at the UO, and we're hitting the backside, and we weren't honestly sure if this would work. If you actually think, like, if you're looking at me, the ureters are kind of going this way, and now we're putting the probe here, and we're orthogonal, so that the vectors don't quite add up for ultrasonic propulsion. But when we hit the backside, if it's like about to go, we can speed that along. You could make the argument like that was going to pass anyways, and that's a reasonable argument. It's fun, but actually, we'll also talk about it. We're probably doing a little bit more than just getting a stone that was likely to pass. Like we're kind of getting it unstuck. Let's move on. So I think BWL has maybe more promise, but honestly, I think they actually work together. And this is burst wave lithotripsy. On the right, you're seeing. Actually, did I? Here we go. Okay, sorry. My transitions are scattered, and now we're back to the beginning. Here, sorry guys. Let me click through here. I'm getting hung up because it has that like presenter view on the side.
Step over here and see what you're doing on the screen.
Yeah. Let me join you. So this is so here we hit the stone, and you can actually see when we hit it, then you get the stimulation of ureteric jetting, and I think that's what's like really helping stones pass. So stones are dynamic; they're not just stuck. It's like if you got your car stuck, you have to rock it back and forth in the mud a little bit to get it out. And so maybe that's how this is working. But it seems that it probably is working. And now let's move on to, all right, so this is BWL now, and on the right there's ureteroscopy, and we're showing this there's like two fragments, so this is one stone that got broken into two fragments. On the left, we're applying BWL, and under ultrasound, you can see at the very end, the stone will break into two fragments. So one, right there, you can see like a little piece break off. And so smaller stones are more likely to pass. This is applied in an awake patient who, I can say experientially, they really don't feel BWL. So we enrolled this was partnering with NASA. We enrolled 55 patients who said, yeah, I'll join your study. And then just a lot of people got excluded. Either our machine was down, or they passed their stone, or we had some limitations with this machine where it had to be within, I think, 7 centimeters to be like a reasonable person. So, or to reasonably apply the force, and so maybe the patient was too big. But 29 then got the procedure. This initially started in the emergency department, and then the COVID-19 pandemic came out, and we couldn't enroll in the ED, so we moved to the urology clinic.
So we gave everyone actually like a kind of mini trial of passage. So if you came in on Friday, you'd show up on Wednesday, and then we'd do BWL or pushing or both. And then we did some analysis on these patients. This is all preliminary data, and so I think all that we can say here is like these are stone size, 4 millimeter, 5 millimeter stones. So they're small-ish, but not super small stones. More males than females. We started this project thinking we could push UPJ stones back into the kidney, and it's a pretty rare stone. And so once we moved out of the ED, we stopped enrolling UPJ patients and really went after UVJ patients. We did a subgroup analysis for the UVJ patients where we looked at time to passage, and there's no comparison here, right? This is just pilot data, so you can't say definitively that patients pass their stones quicker because we intervened on them. But like, if you crack the stone in half, or if you push the stone into the bladder, did you cause passage? I think it's also sort of like, if you jumped out of the plane, did the parachute open? Did the parachute save you? Like, for the one stone where we pushed it into the bladder, there's actually two or three. There were two like that. We aided passage because we definitively pushed it into the bladder. And then days to passage were shorter than an average data passage that we can reference from systematic review and meta-analysis, but for sure, further study is required here. The patients who received either technology had a statistically significant difference in pain reduction, but I don't think you can infer much in a non-blinded trial here either. That is, so this was intra-person pain, so we got their pain score, then we did the procedure and we asked them how they're feeling. I think this is another area where further study is required, but there's some signal there that's encouraging. We at least didn't make people worse. And then related, so propulsion only, 3 patients had discomfort with the procedure. Propulsion plus dislodging, 4 patients. This is how we report it, but they only reported the pain when receiving propulsion. The flicking bothers people, even though it's way lower energy. The BWL, it just doesn't. Our bodies don't detect it. And so in gross hematuria, like 5 people, 42% had gross hematuria for the subgroup analysis where we looked at this, which just our urologists weren't concerned about this. It's common, but it shows that we're applying more force there. So I think that's what's going on. And this is just, people felt the probe warm up, they felt a focal sensation. Some people felt a referred pain, resonant of the kidney stone pain. And then proximal stones, we did 3 of these. We were able to move 2 of 3. I never got the satisfying, what I want to do is push back in the kidney and have it fall into the lower pole. But we did have one patient, this is like the joys of research. We went in, the chair of urology was helping us carry this 400-pound machine out of a van, rolling it up to Harborview on our ambulance ram. And like, we went in, got the patient positioned, and we decided to give them some fluids to dilate up the renal pelvis and get better images. So we were trying to find the right angle. And we went back with our investigational machine, and the patient had, through rolling and Trendelenburg position, repositioned their own stone. We added a liter of water to it. And so we salvaged that one patient with this case report, which I'm happy to report just because of the title. But this is the Seattle stone repositioning maneuver. It's kind of like the Epley maneuver, but for UPJ stones. I'd say give it a try. What's the downside? You're not going to hurt them. But cool. I mean, the stone was there, and I think maybe Dr. Schoenfeld, I don't know if you were a reviewer for that, but thank you very much for your support. This study has limitations. This is pilot data. It has no control. I think that we really need to optimize the technology. We also need to optimize the type of patient. And pain scores are really problematic. There's no validated kidney stone pain scoring scale. That'd be really nice if a future researcher wants to develop that so we can measure kidney stones. But I'd say overall perspectives, we tested a new technology. It seems to work. It was myself, it was endourology fellows, urologists, and RDMS, certified technologists, that were doing this. We let everyone touch the probe. We want this to be collaborative. Most people passed their stone. The procedure was well tolerated in awake patients. And NASA actually took these results from a preliminary report and said, good enough for us. We're going to downgrade the risk of renal disease. We're going to move it from a red to an orange, which means that, like, from the perspective of kidney stones, that this would be like on their ultrasound for when they do extended space travel. It's pretty cool to get to be part of that. However, I would still like them to have said further study is required. Let's continue funding your work. So,
Gotta make it smaller.
Yeah,
Space. It's
yeah.
too big.
So the objectives were just understand that what ultrasonic propulsion and BWL are, so we can do this in awake patients. I'd say, like, we're not ready for prime time, but I'd love to. It's great for me to introduce this and say, go back and build kidney stone pathways with urologists because this technology is coming, and then we can partner with them. And then the final is gain insight. Stones aren't stuck; they're just currently causing pain, and they always are moving, and so we can just continue to facilitate that movement. Any questions? I wanted to do BWL from the very beginning, but the technology wasn't available. So it actually is just how this rolled out. And like when funding came and all of this, so we were at the time flicking with ultrasonic propulsion. It was where the FDA, we were under an FDA ID exemption. And we rebranded flicking as Dislodgement, which was applying burst wave lithotripsy technology to facilitate flicking. And this is all on this. There's a ton of work to partner with the FDA, and they've been really great. But basically, to do true BWL, you can go to even higher megapascals. We limited it to 6, and there's precedent for how this all works. So it was a pragmatic decision, and we just continued to enroll over this time. So the moment that the FDA said yes, and it happened sooner than we thought, we said, let's do this together, because we think BWL is going to make more sense than that orthogonal approach where you're pushing against something that can't go anywhere. It was interesting because from the subgroup analysis, the ultrasonic propulsion alone patients still pass their stones quicker, and maybe that's actually the thing to do because of that peristalsis deal. Like with BWL, it's possible that we cause damage to the ureter and then things swell and things get worse, so it actually delays passage. We don't know, and this is why we have to do further study. But it was really just a pragmatic decision in terms of how the technology has rolled out and working with the FDA. Does that make sense? So all complicated by COVID and then changing the context of doing this in both the ER and the urology clinic.
So you went really fast through the results. There were 2 people who had the sort of instant win.
Yeah.
And then the rest of the people was like maybe you broke it up and maybe it's faster, but the others didn't have the
two patients
emotionally satisfying.
2 patients with ultrasonic propulsion had the win where we like pushed it into the bladder and then the whole room went like it was great. The BWL, we had a few people like stand up and already start passing fragments. So it's a question of like when do you consider that time to passage, and this is a tricky part for future study. The majority of people would pass in the next 24 hours, so they'd pass all of their fragments, but it wouldn't happen. For BWL, we just break it up and then wait and make sure that they're going to follow up. So this is where, we weren't expecting that we would have a fragment immediately pass for those. They were like a little bit higher up in the ureter, but we break it up and watch, and we would call them at 1 week, and then 3 weeks. So like if I were to redo this now knowing what we know from the pilot, I would call them like every hour or give them our cell phone.
So the timing was the other confusing thing to me. So the mean days before you did this was like 9, 10, 11 days?
From an ED presentation, yeah.
So, I mean, I would have thought with, these 4mm stones that so many more, it's already a long time.
Yeah. So this is, I look at like how is that time waiting for intervention biasing things. A lot of these were already pretty stuck stones, even though some of them were kind of smaller. So like, I kind of intuitively say that's our win because we caused it, but you can't say that for sure.
But then it's still another 8 days.
I think it was
after your
2.3 days for ultrasonic propulsion. I think 4 days for BWL. Yeah. So they waited a while,
Is that
and
because of bets when you called them?
we would ask them on survey.
Because we get for these size stones, unless it's because they were really stuck. That doesn't seem so much better than.
Yeah, I think that's the very reasonable counter argument. Like, were we pushing on stones that were already going to pass is really, I think, yeah.
Theoretically, because obviously since feels very new, it's not real for some things, theoretically, what damage could you cause? Like if I
I,
did this to
the very real, yeah. If, yeah, to the eyeball, I wouldn't want to do it to the eyeball.
what's
the worst thing you could do with this technology?
What we do is like we'd have, to get the FDA IDE exemption, we did this in pigs, where you turn the volume up to 11, sort of a thing. The megapascals were, I think, 9 megapascals. It was super physiologic, like beyond what beyond what the machine would be capable of, unless you tore off the governor. And then we would just sit there and cook the tissue and then study injury in pigs. And there was injury, but it was all like deemed as not worse than current, and therefore or not worse than current state, and therefore safe.
Was it thermal? Was it all
Yeah,
thermal?
yeah. And so there's a study that, this is my group that published it on the MRI findings of this and then the tissue findings of this. But like basically there's a ceiling, and then we went like way above that ceiling, and that's where we studied it, and it was still deemed safe. And so we're operating well below the ceiling. So even at the highest megapascals, it's safe. However, we still try to make sure that when you're imaging, and the bladder is an amazing acoustic window for this technology, if there's bowel that were to somehow migrate in the way, or if you weren't paying attention to the probe, and this is why I think like for an evolving technology that's a therapeutic technology that has the potential for harm, really trying to make sure that that there's an understanding of acoustics. At least just saying, I know what bowel looks like. And if bowel was hanging out in the way, first the energy wouldn't get to the stone, so you wouldn't be doing what you're trying to do. But also because of differential impedance, it could cause increased injury to the bowel. So it would be, it's theoretical, but theoretical and enough that I would just say, like, as long as you're pushing with the probe, the bowel is out of the way and you're on the bladder. Even in the UPJs, the bowel, we could get the bowel out of the way. Rachel.
I know, like NO2, but theoretically, those patients that you happen to do it in, was there, when you saw the stone go into the bladder, or how we did it, was there like immediate relief?
Yeah.
The current pain that it had?
Yeah.
The patient sheared as well as the team.
Yeah, the patient cheered. For that, for the stone positioning maneuver, the Pearl and Jam, that person also, when we put it back in, they felt immediately better. It's amazing, like, I through this I have also learned, and there's a case report out there, not by our team, somebody observed somebody with a kidney stone who they heard an audible pop and then went back and the patient felt better. So like, they went and the stone I think had passed, or maybe the calyx had ruptured. I can't remember which one, but like the kidney got decompressed and the patient felt immediately better. The moment that the decompression occurs, the patient feels immediately better, and that was our observation during the trial.
Even if a stone was going to pass by itself, just the satisfaction of you having done it earlier,
Yeah.
I think that's amazing.
That's why I call it like I have a wedding this weekend problem sort of thing. So it doesn't work to follow up with urology next week if I have an important weekend. And now this does become sort of a preference sensitive stone. Like, you know what, I really like, go for it, please. I don't want to go through that again. Yeah. Any other questions? Yeah.
So is this like this would way down the line in the future? This is a machine you not like a specific ultrasound, or can I like snap my snap this probe onto myself?
This is the current machine. It's the one on the right. That's a GE machine that has Sonomotion technology in it. Sonomotion is not a publicly traded company. They're a startup. So if they got, I mean, I don't know. I think startups either IPO or they get acquired. And so if they got acquired by somebody, now suddenly that's baked into your technology and you're selling these. By the way, I forgot to say, I have no commercial interest in this. I think I skipped my conflicts of interest slide. I don't make money on this. I'm not selling lithotripters. I just think the technology is cool. But this company exists as it is right now, and we're going through the FDA submission. But I don't know. I could only say, yeah. Yeah, you could do these machines. The imaging is there's a curvilinear probe and a phase array probe. It's all the same. It's just then there's something around it. So it's fun. Thank you very much for the opportunity to talk about it.